Nigeria is among the 30 high TB burden countries due to limited access to TB screening and testing services. But with support from USAID, the National TB Program, the Stop TB Partnership and aligned stakeholders, Bashir Ahmad, a local radiographer, is able to set up and run systematic rapid screenings in Nigeria's most remote areas. He is on the front line, saving lives, cycling to hard-to-reach communities using the ultra-portable digital X-ray system and computer-aided detection, or AI software.
It's my responsibility to take the examination in terms of position the patient, then we'll collect his samples. CAT for TB is really helping because actually it can detect TB at early stage. That's the first one. And secondly, the heat map can show you the patches around the chest. If there is any patches, you'll see it with your eyes. It's my town, my community, my people. So it's a dream. So I want to give back to them by helping them or by doing this work. It's my passion. I want to follow my passion.
Hello everyone and welcome to today's webinar. My name is Andrea Giacolone and I am the head of business for the country, French-speaking countries. I'm the host for today's webinar, which theme is AI for tuberculosis screening in French-speaking Africa. Challenges, opportunities, and impact. Next slide. Today we have the pleasure of being joined by three experts in Nigeria. So we have Dr Soumana Alphazazi. For Guinea, we have John Hébélamou. And from Chad, Oumar Abdelhadi. Today they're going to talk to us about their experience with the screening of tuberculosis with AI. So they're going to talk to us about what they've learned, but also the challenges that they've faced. Next slide. Before starting, I want to tell you a couple elements that are interesting to be reminded of the first. First of all, this webinar is interpreted simultaneously in English. Therefore, don't hesitate to select the language that you'd prefer by using the interpretation option.
Next slide, please.
Next slide. We'll also have a question and answer session at the end of today's presentation, so don't hesitate to write them down in the question and answers box at the bottom. We're going to answer them, and if we don't have time to do so at the end, don't worry, we'll do it afterwards. As I already mentioned, I am responsible for the French-speaking countries. We have almost 100 people connected. I know most of you. I have the ability of seeing you in person. And for all the new people here present, don't hesitate to write to me. Well, you'll have my email address at the end of the presentation. Next slide. So before starting, I want to offer you a little introduction about our business as Delft Imaging, especially on our mission, our vision, and also the solutions that we offer. Next slide. So Delft Imaging has a long history in the history of X-rays. It goes back to the beginning of the 20th century when we had our first business that was founded. Back then, we were active in Europe and we contributed against TB through providing X-ray solutions, as you can see under the first row of sessions of photos. Back then, the solutions were different, took way more place, and it was we had the film to be developed. The film needed to be developed, so it was a bit more complicated, and we had a whole setup to be put in place. Over the years, Delft Imaging was able to invest a lot in terms of development research, and so we continued to offer options to fight against TB in other countries, especially in Africa. And so today, as you can see on the second row of pictures, now we have the possibility of offering different solutions and also softwares of interpretation software of the different X-ray images. But I'll talk about it a little bit later. Next slide. I would like to share with you also something that's important at Delft. Delft is a social enterprise. This means that our main goal, is to offer a social difference, a positive social difference. And therefore we do it by offering innovative solutions destined to better access to care to all the different communities. Delft Imaging every single year publishes an annual impact report, sharing with all the stakeholders, everybody that's interested also, to know more about it. Don't hesitate to go on our website. Well, you will be able to see all the projects that we've accomplished throughout the years. Delft Imaging is also part of the Million Lives Collective, meaning that through our solutions, we were able to reach the lives of a million people who were living with less than $5 a day. We also joined the United Nations Global Compact, so we are working in an ethical and sustainable way. Delft Imaging is also B certified, recognizing the businesses that had a big impact on the environment and also socially. Next slide. I would also like to talk to you about our structure. So Delft Imaging today has different offices. Our headquarters, of course, are here in the Netherlands, but we also have two African offices in Ghana and Nigeria, and also in Indonesia. But what's more important, I think, is the fact of reaching more than having our solutions in more than 85 countries is due to the strong collaboration that we built with our local partners. So in all the countries that we publish those projects, we now work with local partners that are responsible for the follow-up on the ground and supporting the different speakers. I am now proud to say that Delft Imaging was able to serve more than 2,400 healthcare facilities and was able to train more than 2,800 health professionals. And therefore, I can share with a great pleasure that through our solutions, we're able to reach the lives of more than 32 million people. Next slide. Now I'm going to show you a little bit our systems, our digital radiography systems. Those systems are presented by how easily they are to be transported. So first ray, you have the stationary system, for example, as EasyDR, Compact DR, and containerized clinic, with a lab also room to contain any TB bacteriology. Then we have mobile solutions like the MAC or the one-stop TB mobile clinic. It's like the container. It's divided in 2 or 3 rooms, and this is allowing you to do the screening from the X-ray to the bacteriological confirmation. I also like to bring the attention to the fact that all the solutions presented here were done with and for the community, specific, destined for the use of the people in the places that are with low revenue. And then we have ultra portable to go in the further places. It's the Delft Light Backpack and the Delft Ultra. On the Delft Light system, I would like to add a little something. I noticed that today the Delft Light system is the most used against tuberculosis for many reasons. First of all, it's a multifunctional system that can allow us to do more than 400 images on 2 batteries. And it's also a system that's equipped with a solar panel to allow for the charging of the different elements. And then Delft Light was also created to be used by technicians and health professionals. This makes the usage simple and easy to put in place. Of course, the choice of the system depends on your context. Next slide. Now, I think that Delft was probably the first business to develop an AI system to fight against tuberculosis. This software is Cat4TB. Today, this software was published by more, recognized by more, published on more than 400 publications. And this software can detect tuberculosis. And today, with that new version, it can also detect other pulmonary problems and heart diseases. Cat4TB software is available through the Cat4TB box that can be used offline or through the cloud for an online use in case of an internet connection present. The software is also has a platform, the Cat4TB platform, that is made of 6 modules. First one allows you to record the different patient data. The second one to write all the symptoms. The third one to visualize the different images, X-ray images, and also interpreted by AI. Fifth module will allow you to have the report that you can share with the patients or your colleagues. And finally, the 6th module to have to adapt according to the data that you have received. After the training, I think that one of the many important things that come up is really that. So I think that support on the ground is really important. As I was saying earlier, through our large network of local partners, we can ensure a service on the ground in most of the countries, but also through the collaboration that we have between the different offices in Africa, where we can easily have training sessions done on site. Then we also developed the training online platform through the e-learning so that they can refresh their knowledge, or for all the different new people, it's also a way for them to know and get acknowledged with that system. All the solutions that I mentioned are available through different catalogs, including the GDF, PF, SCM, and UNY by Plus. Next slide. So to conclude this part, I think that there are different positive elements and strong elements in Delft Imaging The first one being, of course, the possibility of offering complete solutions both for hardware and software. This allows a real management, efficient management, but also a global presence. To really start the projects even in the farthest regions. Of course, also to make sure that the different systems, Delft system, even with the different projects that we published 10 years ago, are still good today. We have a system that is used on the long time and tailored also to the different users. So it's important to follow the different recommendations of the teams, of Delft teams, during the use of those technologies. I think another important point also is the training. Everyone knows English, but having training sessions in English is harder than having it in your local languages. So I think it's easier to have it in your local language. Thank you. Thank you, Alain. I've finished my presentation. It was just a little introduction to start with. Here you have my email address. So don't hesitate for any questions that you may have. It will be a pleasure for me to talk with you. Thank you very much.
Next slide, please.
So now we're going to welcome Dr Soumana Alphazazi, pneumologist and phthisiologist, National Coordinator of the National Tuberculosis Control Program in Niger, and National Consultant for the Union within the framework of the CETA project in Niger. He's going to present to us the mass tuberculosis screening in vulnerable groups using X-ray with CAD in the city of Niamey.
Dr Alphazazi, je vous donne la parole.
The floor is yours. Thank you, Andrea, and welcome. Good evening, everyone. It's a pleasure for me to talk to you today of this actual screening of tuberculosis in Niger in the case of the use of the X-ray ultra-portable solution with CAT for TB. Before starting, I would like to thank very thankfully Delft Imaging for the trust that they gave us, the trust they gave myself to present, but also thank all my collaborators for this program, all my colleagues, both here on the ground and also in the country, for that collaboration, which allowed to have the different results presented in this presentation. I would also like to thank Dr. Vicha for the technical assistance, because this project is put in place with his collaboration, with his technical international help. We've been able to put in place that project. So we're going to talk about, firstly, of the project, first of all, in and of itself, and then go more specifically talk about the screening with the X-ray, the results that we're able to receive, and what impact did it have, did it lead on the program. But we're going to finish with the lessons learned, the different challenges that we've faced, and then conclude. This is our plan very shortly. Next slide. So I'm going to talk about the active TB screening in vulnerable groups using ultra-portable radio in the RECAM project in Niger. Next slide. Before starting, of course, I would like to talk to you about the context. Niger is a big country of more than 1,000 square kilometers with 26 million population, with a TB incidence of 74 for 100,000 inhabitants. We see a decrease in that incidence and the treatment success rate at 88%. We have a good treatment coverage that is getting better over time. We went from 66% to 80% in 2023, but still we have rationale for the intervention that cases that are not being treated. Therefore, we have, through the program that we led in 2020, we were able to see where are those missing cases that we do not have, we do not find, and when we found them, about 41% of those cases, those missing cases, were in 4 regions here, the 4 regions of Zinder, Marabi, Tillabéri, and Dosso, which led us, therefore, to put in place a project to better the TB treatment coverage and reinforce the active research for the screening. Next slide. So the purpose of this project that we named RECAM, Research of the Missing Cases of Tuberculosis, is to organize and implement an active TB screening strategy among identified at-risk populations in order to increase the number of TB cases reported in the intervention areas by 15%. The process that we led and that we followed to elaborate that project was especially the first part of a data analysis in the operational part with literature review. We reviewed our algorithms to put in place a screening, an active screening with X-rays, with the portable solution. And we also did some trainings with cascade training, preparation meetings, and implementation of the project was from 2022 to 2024. Next slide. Here are the different interventions that we defined in that project. We had 3 of them. First implementation period was the approach of quality with using therefore that project with high frequentation. So we recruited different people that put in place different questions to screen the different cases of the patients that are coming. And as soon as the person has signs to suggest tuberculosis, the agent there is going to orient him towards the doctor or the nurse that's going to do so that he can go into the system. Second intervention that we had was the survey of bacteriologically confirmed TB cases, TB positive. And we went from the lessons learned during the union's CETA project MIO. It's the project contributing to the elimination of tuberculosis. And so from there, because we have pilot sites in the country, from there we went further to the different areas to work on that project. For all patients that are bacteriologically confirmed and to have the survey on all of them, we went to their houses to see if there were no other cases and tried to break that transmission chain. And the third intervention that we put in place was a screening campaign with ultra-portable X-ray with CAD, and we put this in place in the vulnerable groups. In the different groups that we are going to define, so in the prisons, in the mining communities, and the different traditional communities, the different refugees, but also in the migrants, also in different regions. So the intervention coverage, you saw that there were 4 regions where we worked. But after the first year of implementation, we added Niamey because Niamey, we saw that there were some difficulties with the setup in place in Tillabéri because of insecurity problems in that region. Next slide. So here's the project. We had the first implementation phase in 2022, and after that, the implementation phase was 2023-2024, and then we were able to convince the state to help us there to put in place some interventions from 2025 to 2026. And from there, as I said it before, we revised our algorithms and bought the tool and trained different professionals on how to use it and how to interpret the different images. And then we had some screening campaigns. Next slide. So what are the different interventions that we had? We had a screening campaign in the prisons. We included the prisons of the different regions, but we were not able to do the Niamey prisons. Also, we had them in, we had those campaigns in centers that were screening via HIV. An NGO was taking care of those populations, and also the center of taking care of the different patients of HIV, which is mobile. That is in the case of the screening of HIV. We also bought a mobile vehicle that is equipped with X-rays to do that screening, that mass screening with the immigrants and the different nomads in the areas that is an area that's very known for that. We also had an organization in the refugee camps and internal displaced people, places where you have conflicts, the region of Difa, Tillabéri, where there are a lot of people that are displaced, linked to the insecurity and the conflict. Next slide. So all those strategies allowed us to have results. If we take the first approach that I told you about, the fact of sending the triage personnel in the different consultation sites, this allowed us to screen 6,917 cases of TB in those 4 regions between 2023 and 2025. Because the first year, because it was a preparation year and setup of the project, year 2022, we didn't have results. Next slide. The second strategy that we put in place was investigating the contact cases, meaning that we were visiting the different people who were screened to see if anybody else was also infected. And through that strategy, we were able to record 327 cases of TB between 2023 and 2025 in those 5 regions. Next slide. And therefore, with the 2 campaigns that we put in place, if we take both strategies that we try to put in place, the 2 different approaches, they allowed us to have 7,244 new TB cases. And if we try to do separate them between the notified cases of TB, this is about 14% of the notified cases in 2023, 25% in 2024, and about 22% for the first quarter of 2025. of the entire cases present. Next slide. So about screening campaigns with X-ray, we were able to bring the different screening campaigns in the prison areas and also the different places taking care of HIV. We also led campaigns in the poor quarters in Niamey, and through that strategy, we were able to detect and to screen 18 cases of tuberculosis, and among them, there's a case of tuberculosis MR that we're able to detect through that strategy. When we do that total of all the strategies, we detected this project, this weekend project, allowed us to detect 7,262 new cases of TB in Niger. Next slide. Now, what was the impact of that project in the different regions that where we put in place that strategy? Every year, it led an augmentation of the different screening, except in the Dosso and Tillabéri regions, we had a decrease due to, of course, the insecurity that's present there in the country. So some areas of that region were affected to insecurity problems. And in the Tillabéri region also, it's the area that's very at the frontier between Mali and Burkina, which is why we had a lot of people that moved around, which is why in 2024 we had the decrease in those two regions. But you can still see that in Marabi and Zinder, we had an increase, a progressive increase of the notification of those new cases in those two regions. Next slide. We tried to look also at the total of the cases, the notification of the cases that were expected. When we noticed that when we reviewed those, we had about 8,000 cases of 2020 that were missing, that we're not able to screen, and this strategy allowed us to reduce those missing cases to about, we went from 8,000 cases of missing cases to about 3,140 in 2024. So you can see that on this slide, the reduction of the missing cases is progressive because we are notifying way more and more cases. Next slide. Here are the key achievements that we were able to realize. The increased straight treatment coverage. We also implemented a systematic screening for TB signs and symptoms at entry points in through triage officers. This strategy allowed us to implement the active screening of X-rays and with the CAT for TB for at-risk and vulnerable populations. And it reduced also the chain of transmission because it allowed us to diagnose in time some tuberculosis cases that were contagious. Next slide. Now, the key challenges that we met were especially the case of sustainability of achievements through a systematic integration of lesson learned. The early detection to break the chain of transmission, because the question should be, the country is vast. We have a very big country. So just one device that we have for the moment, unfortunately, we have a decrease in the financing for TB screening. So the question of another device becomes more hypothetical, and we are reaching other partners also to see how we can get those. Next slide. As a conclusion, I would say that tuberculosis remains still a serious problem in the public health. A lot of progress was made, but the path is still long. But when we do see the reducing of the finances, the integration of the fight, innovation especially, innovation through the placement of those new technologies that we are integrating in our programs. We have also the mobilization of alternative resources that remains the only ways to hope to achieve the goals of ending tuberculosis by 2030. Before finishing, I would like to present to you a couple images. Next slide. You can see here an image of the training, the online training that was put in place for the different actors with the support of Delft Imaging in Ghana. Next slide. Same training once again. Next slide. This is the preparation images for the mass screening in the poor regions. This is the technician, X-ray technician that's ready to welcome the people. Next slide. So this is the different material that we put in place. Next slide. Those are the different images. An image of a case that we screened. Image, of course, is not super good here on the. Sorry for the quality of the image, but you can still see it's on those cases where the left lung is almost gone, especially on the left. Next slide. I'm gonna finish by thanking very much all the partners here presented for the very good collaboration in the fight against tuberculosis for Niger. Thank you very much for your attention.
Merci, Dr.
Thank you, Doctor, and great job in Niger for these results. Amazing results. The missing cases really reduced, so I think that for the future you will be able to continue that work on a larger scale. Now we're going to go to the second speaker. I have the pleasure of welcoming Dr. Jean Hébélamou, who will present to us today clinical cases and his presentation facilitating computer-assisted reading of chest X-rays for tuberculosis screening of the Macenta Regional Hospital Center, Republic of Guinea, presentation of clinical cases. Dr. Hébélamou, I would like to know more. Here's for you.
Docteur Hébélamou, ok, c'est parfait, merci.
Okay.
Hello everyone. Thank you for allowing me to speak. I'm Dr. Jean Hébélamou. I am the Deputy Director General at the Hospital Center, Specialized Center of Macenta. I have the honor and the pleasure of presenting to you the theme. Next slide. That is facilitating computer-assisted reading of chest X-ray for tuberculosis screening at the Macenta Regional Hospital Center, Republic of Guinea, presentation of clinical cases. Next slide. For this presentation, we're going to follow the plan. First part, we're going to have a small introduction. Then we're going to look at our main objectives, our observations that were made, and then a conclusion. Next slide. So indeed, the Regional Hospital Center of Macenta is a center specializing in the treatment of leprosy, tuberculosis, and HIV. X-ray, the conventional radiology that we use today was installed in 1898 and worked until 2023, year in which automated interpretation of digital radiography was introduced by the Missions Fil Africaine, which is our main partner. Next slide. We should say that tuberculosis is an infectious, contagious disease of bacterial origin that affects the lung, mainly, and it is caused by two types of bacteria spreading through the air, transmitted therefore by infected people through coughing, sneezing. Tuberculosis is therefore a preventable disease that is curable through a well-led treatment. Next slide. There's about 1/4 of the world's population that is infected with tuberculosis, and in Guinea, the incidence rate is of 100 to 199 cases per 100,000 inhabitants per year. And therefore, as a definition, TB is a contagious disease caused by Mycobacterium tuberculosis. Next slide. The main objective of that presentation is to report cases of tuberculosis diagnosed by Dutch digital radiography with CAT for TB at the Regional Specialized Hospital Center in Macenta. Next slide. The first clinical case was about a woman of 36 years old who was a merchant from Sougiri, that's located north of the country, in 454 countries north of Macenta. She was admitted April 14, 2025, and her complaints were cough, fever, dyspnea, and vomiting. The progression was approximately 3 months. She had no particular medical history, no defects, no history of tuberculosis infection. Next slide. When she was admitted, she was conscious, cooperative, and had an active attitude. Height 174 centimeters, weight 52 kilos, and a BMI of 17.2. Lungs showed crackling rails in both lungs. Other systems had no problems to note. Next slide. This patient showed an chest X-ray with infiltration scattered in both fields in the right lung, as we can see it. And the score showed us an 84.750 score, therefore a possible TB. Next slide. In parallel, we also asked a gen expert, and it revealed positive, of course. Also, when this patient, when we offered a screening, she was already on a retroviral treatment. And therefore, with that co-infection of HIV, we added the DTG. So the anti-tuberculosis treatment was instituted. 2 months of 2-RHZE and 4 months of RH that were offered for that patient. Next slide. The second case was about a 41-year-old man who was a farmer from Guayama, who's located 140 kilometers from Macenta. This patient was admitted May 31st, 2025 with complaints of cough, fever, dyspnea, physical asthenia. The evolution of it was approximately 4 months. He had no particular medical history, no defects, on no history of tuberculosis infection. Next slide. When that patient was admitted, he was conscious, cooperative, and had an active attitude. Height 171 centimeters, weight 52, BMI 17.8. Lungs showed a crackling areas in both lungs, and other systems had no problem. Next slide. X-ray was also realized for this patient. As we can see, of course, on this image, we had infiltrations scattered in both lungs, and the score showed us a value of 84.97, therefore a possible TB. Next slide. The gen expert was also required. It revealed itself to be positive, detected T, and HIV status was negative. The anti-tuberculosis treatment was also presented at the same cycle. 2 months of RHZE and 4 months of RH. Next slide. The last clinical case was a man of 73 years old who was a farmer from Kirwane, who's located 127 kilometers from Macenta. He was admitted April 10, 2025 in our center with complaints of cough, fever, dyspnea, hiccups, and dysphonia. His progression was approximately 1 month. He had no particular medical history, no defects, or no history of tuberculosis infection. Next slide. This patient, when admitted, was conscious, cooperative, and feverish. Height 163 centimeters, weight 47 kilos, BMI of 17.65. The lungs showed no rails, and the other systems had no problem. Next slide. X-ray was conducted for this patient, which showed the images that you can see here of infiltrations in both lungs. The score showed us a 94.810, therefore a possible TB. Next slide. Here, the gen expert that was required was not detected, so therefore negative. The HIV status was also negative. And therefore, the diagnosis of tuberculosis miliary TB was therefore retained. And therefore, we tried an anti-tuberculosis treatment with the same treatment of 2 months RHZE and 4 months RH. Same pattern as the different patients back then. Same. Next slide. We should say also that this last patient, 2 weeks after putting that treatment in place, the fever had lowered, and also the other symptoms. And therefore, we said, on admission, if there was no good evolution, we should consider the following differential diagnosis with other diseases such as autoimmune fibrosis, sarcoidosis, and silicosis, especially because the patient was coming from a mining area. Next slide. As a conclusion, we should say that tuberculosis is a public health problem in sub-Saharan Africa. The performance of automated reading helps to better interpret images and to diagnose tuberculosis quickly. Its use could increase the detection of tuberculosis at the Macenta CHRS. Next slide. However, this new diagnosis method presents challenges because all TB cases are still being reported, even if the patient took its treatment correctly, because the system is still going to show it as being a new case, and it's not specific, therefore, to active tuberculosis. This does not also rule out other diseases with a similar differential diagnosis to TB, with which therefore we have to do a differential diagnosis. So it's important, therefore, to introduce those diseases in the CAD framework. We want to thank you, therefore, for your kind attention. Next slide. Thank you for your kind attention. Thank you, Dr. Hébélamou, for this interesting case and the clarity of your presentation. For those who are just connected, I remind you that this webinar is translated simultaneously in English, so don't hesitate to click on the interpretation button and to select your preferential language. Then I also remind you that at the end of this session, we'll have a question and answer session. So don't hesitate to ask them in the question and answer box. Next slide. And now, to finish well our session, I have the pleasure of introducing Dr. Oumar Abdelhadi, coordinating physician of the National Tuberculosis Control Program in Chad. He's going to present to us the artificial intelligence for tuberculosis screening in Chad, challenges, opportunities, and impact. Dr. Oumar, over to you. Thank you. Thank you, Andrea, and thank you, Delft Imaging, who's giving us this opportunity of presenting what we're doing, the fight against tuberculosis, especially with the use of AI. Allow myself also to present to you my team who's going to accompany me from the beginning to the end, and they are here today to follow that presentation. We also want to thank Delft, who really helped us to continue and to have a strategy even when we had issues on the ground. We also want to thank Dr. Mosha, who helped us to better the quality of our presentation. And finally, thank you to the team who helped us to have this tool to do that. I will now do this presentation on AI for tuberculosis screening in Chad, challenges, opportunities, and impacts.
Next.
So our presentation plan will be on these points. We're going to have an epidemiological situation of tuberculosis, specific intervention, and some activity packages, and the screening the results of active TB screening among nomads using AI in different key populations. So the nomads, in the detention center, in the refugee camps. We're going to talk about the challenges, the opportunities, impact, and then have a conclusion.
Yes, you want next. Next.
So, about epidemiology, you know that tuberculosis is one of the real health problems that we have here. In here, Chad, we have an incidence of tuberculosis that is estimated at 139 new cases per 100,000 inhabitants per the 2024 report. This, applied to Chad population in 2024, gives us about 27,000 cases of TB expected. But we were able only to detect 16,902 new cases, and that were able to be put on the treatment. And there's a gap of missing cases of 37%. We should also say that the 2023 cohort that was put in place helped us reach a success rate of 84% of cases successfully treated. About the collaboration for HIV and TB, we were able to test 93% of tuberculosis patients for HIV, and 8% were confirmed. Right now, we have 120 TB treatment sites with 54 gene expert machines, which help us to detect tuberculosis. So a good part of our centers are using those to detect TB. So if you look a little bit at the card of our country, the notification cases kind of change. It's more presence in the area where you have an easy access to health services, but also where the population is heavier. And so this is in our different regions, and most of the regions in the north and center have low notifications and rate. In the north, you have about 550 square kilometers, so it's not a lot of people that are living there, and they have higher chances of not reaching health centers. Therefore, we have a lower treatment there, and the interest of using that mobile strategy with the use of AI is therefore important to use them in those areas. Next slide.
Next.
Because of this problem, here are the specific interventions that we developed to address this difficulty. We developed a strategy to reduce the number of people missing from TB surveillance. And we, through financing, we bought a Delft truck equipped with an X-ray machine with AI for TB screening as part of a mobile strategy. We also identified key vulnerable populations and priority sites, and developed, therefore, through X-ray, we're able, therefore, to detect. We also developed algorithms tailored to the key vulnerable populations identified. Next slide.
Next.
So to put in place this strategy, we had a strong involvement of the community and a collaboration also with prison authorities and administrative authorities to put in place the search for missing persons from TB. For this, therefore, we developed a number of deployments and health training centers of the groups that we mentioned. We trained 220 health professionals, where you have more cases of tuberculosis in the 5 major cities, and we train also 90 nomadic health professionals. Around 15 health centers located in transhumance corridors. We trained 120 cell leaders from 12 detention centers to raise awareness about the signs of TB prevention, screening, and adherence to TB treatment. And then we trained 100 health workers in refugee camps in eastern and southern Chad to help implement that strategy. Next slide. So we had activity packages for community health workers that were put in place. We had raising awareness about tuberculosis. We identified people suspected of having tuberculosis. We referred to people suspected of having TB to TB treatment centers. We supported patients undergoing TB treatment. We searched for patients who had been lost for follow-up, and we had contact tracing of people who were confirmed TB. Next slide. So here are the algorithms that we use for those populations. Those algorithms are normally known in the different countries, and we had applied those algorithms. It starts, therefore, by a verbal screening, and then we do X-ray, etc. In the detention centers, we start doing by X-ray screening, and when you have signs of TB, then we do a test. But this is things that I'm sure you know already, and I'm not going to go hard on this. Next slide.
Next.
Here is the result of the different activities that we're able to do in those populations. Among the nomads, we really targeted 9 sites. 9 sites where they are staying in order to do the screenings for AI, for TB. Using, of course, X-ray with AI, and also using the gene experts. So for those nomads, we recorded 667 people that were registered. They did a verbal screening, and among those who had the verbal screening, we had 200 that were suspected to TB cases, according to verbal screening, and where they were referred to X-ray. 207 who did X-ray, 20 people, so 9.7% of them had abnormal X-rays. And they were also referred to gene expert and did the test. And among them, among those positive to do X-ray, 5 were confirmed TB cases that were sensitive and started treatment. Next. Among the detention center, as we said that the initial diagnosis starts with radiography, with X-rays, we visited the 12 detention centers. Among the 40 of them, we visited 12. And in those 12, 5,511 people received X-rays. They were screened with X-rays, and among them, 385 people, 7%, showed signs of TB according to the AI. 25% of those who had abnormal X-rays according to the AI were tested using gene experts, of whom 96 were confirmed. Next.
Next. Pour ce qui concerne les
About the
réfugiés,
refugee camps,
nous avons aussi visité 9 camps de réfugiés.
we visited 9 camps in the center, north, and east of the country. This allowed us to do this work for 938 people registered. They had a verbal screening, and of whom 592 people, so 63%, were suspected TB cases who underwent X-ray screening. Among those who did X-rays, 75%, so therefore 12.7%, had abnormal X-rays according to the AI, and therefore they underwent gene expert testing, of whom 21 were confirmed TB cases. Among the 21, we had 7 that had a TB MR, multi-resistant tuberculosis, and 1 who had a pre-XDR. Next slide.
Next.
And so together, during that period, we screened 7,116 people. Among those people who had the verbal screening, 6,357 had underwent checks X-ray, so an 89% of them. Among those who underwent X-ray, 589 people had an X-ray showing got cut off, had X-ray with abnormalities. Among those, so all of them underwent a gene expert, and 112 of them, therefore 19%, were confirmed by gene experts. And 1.6%, therefore, of registered cases. And all 112 of them were enrolled on treatment.
Next.
So now what was the success and impact that we faced? You know that in our countries, X-rays is a luxury. And when we have that equipment and that is coming closer to the population freely, there's a real adherence of the key vulnerable populations, but also of the authorities, whether administrative authorities or penitentiary teams. This was really appreciated by the populations and the authorities. This was the first success we had. The second was also an important one, was that there was a real improved access to TB screening and diagnosis for vulnerable populations through the use of AI. Therefore, we quickly notified cases that we put in under treatment to stop transmission of TB of those key populations. Third success also is that we're able to improve TB data collection, especially among key population. Because in the past, we did not have enough information on those populations. And through that strategy, we can therefore have a better organization of those specific populations. Next. In terms of challenges, as my colleague was saying earlier in the chat, it's a big country. Chad is a big country. But unfortunately, our means did not allow us to have more than one truck that is equipped with AI-enabled X-ray technology. So as you can see, the whole part here in the north and center needed that. And needed, therefore, the use of X-ray technology with AI to increase the notification of cases. The other challenge that we faced was the limited capacity to renew the AI license. And here, we really want to say thank you and congratulations to Delft Imaging, because for diagnosis, we've always communicated with the Delft Imaging team, who really assisted us immediately. So despite the license ending, they still helped us to be able to continue to do the screening with AI. And for this, we're very thankful. Beginning of 2025, we were able to renew our license for 3 years. So we really want to thank this collaboration with Delft Imaging, which really helped us to continue that license, to not lose this diagnosis. But we also have a limited capacity to maintain the truck, because this is a specific truck, and even the equipment inside do not have any specialized people to maintain it. So that's a challenge. So we called Delft Imaging through its representatives in Ghana, and we tried to find solutions to continue to work for those populations. The other challenge, it's not the lesser, is that we had difficulty in resolving discrepancies between X-ray results and GeneXpert results. As you've noticed, on 589 people who had an abnormality in the X-ray through AI, only 19% were confirmed through GeneXpert. And here it was a real challenge. So to find a solution, we communicated with specialists to decide for whom we had to start the treatment. So our colleagues and specialists always stayed connected to us to answer. And about this discrepancy, it presents another question, because the results in themselves and the diagnosis through CAT4TB should be closer to the molecular diagnosis. But because AI has limits, our colleague as was saying, our colleague in Guinea, there's questions that are asked. Is there still a problem on the specificity of AI to diagnose TB? Is there a manipulation of GeneXpert to say that the results are different? There's a lot of questions. But still, there were questions that we had to face, because sometimes they take GeneXpert with them, sometimes on the ground. So we should not have those discrepancies and try not to have them as least as possible, at least. But we still tried to put ourselves in the different situation of GeneXpert. And we still have questions. Why are there so many discrepancies between the X-rays and GeneXpert? I think our colleague from Guinea also said that it's things that are not tuberculosis sometimes, but they have the same symptoms and are recognized through X-ray as being tuberculosis. So this is a real question that we have to use to maybe better it, and how to also better our strategies using GeneXpert and X-rays. Next slide. As in opportunities, we really want to say that we have a prioritization of TB screening activities in the mobile strategy with use of AI, and that was a real opportunity for the health ministry. And that was really congratulated for its strategy. This is a real opportunity for us. The other opportunity is that the Global Fund, which is the main partner for the search of TB, has a substantial support for us in the search for missing TB cases. Next. As a conclusion, therefore, we keep in mind that the use of our AI for tuberculosis screening in Chad represents a significant advance in the fight against this disease. However, challenges remain and require special attention to ensure the success of this initiative. To conclude that presentation, I would like to say the use of AI with X-ray with AI is going to continue to better our use, and it can contribute, therefore, of this strategy that we want to end tuberculosis by 2030. I want to thank you for your kind attention. Thank you, Dr. Oumar, for this presentation, for this clear presentation and the sharing of the different algorithms used, the different populations that you had. If you have any questions for all the doctors that presented here today, I encourage you now to ask them in the question and answer session. I already see actually that there are some questions, so we are now gonna take a moment to answer them. I see the questions for Dr. Alphazazi. He's asking about your presentation. How many team members are engaged for ACF, active case finding, and how do you confirm the cases of tuberculosis, and what is your initial loss to follow-up rate of whom diagnosed from ACF camps?
Je peux aller rapidement?
Oui, c'est la parole à vous.
Over to you.
Merci.
Thank you, Andrea. Thank you to everyone who put their nice words in the chat or the questions, and for appreciating our presentations. About this strategy, we have different levels. We had the international instance that helped us also, and then we had a team that was put in place in the country that contributed to those results. Also, operationally, we trained different triage agents in the country. About 300 triage agents that are in the health centers trainings, and in the health center trainings you also have the screening centers of TB, but you also have health trainings that are not TB centers. We also trained the different radiologists in the 4 regions. We trained doctors to interpret the images, and also to CAT for TB, to interpret them through CAT for TB. So we said that we had to do that training so that they can interpret it. Also, for the detention centers, we trained all the nurses for the tuberculosis screening in those 4 regions. We had 2 sessions of 24 people, and we also trained educators. We also trained for refugee camps. Unfortunately, the financing was not able, did not allow us to do large scale trainings, but we decided to do those campaigns in the migrants' home, in the regions, etc., in the different regions to reach directly and to go to the end of the journey with them. So as long as it's patients that are screened, they are directly sent to the national center that's taking care of the tuberculosis to be taken in charge. So we did not have any loss about that. We directly led them. But about the other patients, there are, of course, patients that we are losing sight of. But that's very minimal compared to what we have. I don't remember the third question, what it was. I'm sorry, if you can remind me. The third question was, what is your initial loss to follow-up rate of whom diagnosed from ACEF camp? The active case of active research, we did not lose any clients and any patients. Active case finding, we take all the dispositions possible so that those cases directly come to integrate the system. We did not have all the expected cases, of course, because we go to people, we offer them the radio, the X-ray, and as the doctor was saying, Dr. Oumar was saying, it's a luxury for them. And in our populations, the use of X-ray is a means that it was really going to help the population adhere. And we are going to be able to detect very early some cases before any symptom. And it will break the chain of transmission, because if the sick person starts to cough is already starting to transmit it. But if we detect it beforehand or while it's still in the infiltration or nodules, it's amazing. It's what we wish. And through this, we can break the chain of transmission. And through this, we can also end tuberculosis in the country. But if we leave people in the different populations to spread the disease, then it will only increase and make it hard to control it. Because one person contaminates about 2 to 3 people per year. So with the classical method of if the person we have to break that chain. And therefore, I'm pleading so that this strategy of screening with X-ray and AI should be the first tool of diagnosis use, because people adhere to it quite easily, and it allows an early diagnosis or to stop the chain of transmission. That's it for me. I think I answered that first question. Thank you. Thank you very much, Dr. Alphazazi, for your answer. I now have the pleasure to invite Dr. Hébélamou to answer some of the questions that were asked to him. The first question is linked to the score, to the scores chosen through the CAT for TB software. What score was chosen for the triage of tuberculosis? You're still muted. The score recommended when it's above 60%, we think that it's one suspected case of TB. If it's above 60, we really think that it's a possible case of tuberculosis, above 60%. That's what I could say. Thank you very much, Dr. Hébélamou. I have another question for you. How can we differentiate a current disease or a previous one? So, when we look at the different images and the radio shows us that it's a real active case of tuberculosis, we present a survey asking the patient, when did you take that treatment of tuberculosis? And sometimes we have old treatments with us and we say, did you take that type of medicine beforehand? The person's going to say, yeah, I took that meds for some time, for 6 months or 3 months back then. And it's on that basis that we're going to differentiate the different cases from the new ones, the old cases from the new one. We are just asking them questions. That's what helps us if that person was exposed or it's documented through the treatment chart. If we can also see that, we think that it's an old case of tuberculosis. So the patient folder is important. Thank you very much. I think it's quite unique and a great pleasure of hearing you. I see among all the participants many people that are interested and that did not have the possibility of getting familiar with that technology. So having a real idea of the use of it and your recommendation is very useful. Thank you. So now I would like to ask 2 questions to Dr. Oumar. I see that we have 2 questions for you, doctor. First question is linked to the reaction of the community. What reactions did you face when you searched active cases? What are the different elements that of their reactions when screening for them? Thank you, Andrea. First of all, I'm going to answer the question for all the different speakers. What are the scores retained to say that tuberculosis is confirmed? We try to confirm it with gene expert. So as soon as we have a score of 40, 50, then we go to gene expert to see if that's a case or not. About the reaction of the population, as I said, the reaction was positive, really, because everything that they learned, the different delegations are calling programs to say we have an intervention here in that area. And there are real testimonies of people. People who benefited from it were really amazed and happy because we were facilitating access to those services. They were really happy and they really sent messages to the program to show their satisfaction. Now, through the district, through the delegation, we also have testimonies. And I think we recorded some testimonies of our community. They were really satisfied. It was not something easy for them, but the X-ray with those images in color, it was amazing for them because even some people, they can see in what area from the lungs they have that issue. So it was amazing for them. We had real testimonies from the authorities. When we go in an area, we see first the authorities. And they really thanked our approach with the use of the different modern tools. They were really satisfied. Thank you. Thank you, Dr. Oumar. There's still a lot of questions, but you will have access anyways to the recording of that session and also to the question and answer room. So now we will answer them afterwards. For now, I'm going to finish the webinar with a great thank you to all the speakers and also to all of you, the participants, for your presence and your attention along this session. Thank you very much.